European School of Oncology. The e-session will start soon. Thank you for your patience. Today's e-session will start at 6:15 p.m. Thanks for waiting. European School of Oncology. The e-session will start soon. Thank you for your patience.
Good morning, afternoon and evening. This is the conference operator. The European School of Oncology welcomes you to the e-session 589,000. Today's session is Case Discussion on Advanced Breast Cancer, EBR Program. Please note that this activity is CME accredited. At the end of the presentation, go back to the ESO website to complete the evaluation form and the CME multiple choice test. Mastermind competitors will be prompted to start the quiz after having completed the evaluation. As a reminder, during the live session, all participants can ask questions live at any time by simply pressing on the relevant button at the bottom of the page. Questions will be received by Dr. Fatima Cardoso of the Champalimaud Ward Clinical Center, Lisbon, Portugal, and Dr. Alexandru Iniu of the Interdisciplinary Cancer Service, HRC Hôpital Riviera Chablais, Rennes, Switzerland, who will discuss them with Dr. Maha Al-Sendi of the St. Vincent University Hospital, Dublin, Ireland, Dr. Marina Piachinskaya of the Minsk City Clinical Cancer Center, Minsk, Belarus, and Dr. Lucia Kamenchzik of the Juana Fernandez Hospital, Buenos Aires, Argentina. Here is an extract of the policy which is published on our website in full. I will now hand over to Dr. Cardoso. Doctor, your line is now open.
Hello, everyone, and welcome to this ESO case discussion session. So today we will focus on advanced breast cancer, and we have three different clinical cases that we will discuss. So the way we will run it is that we will present one case and discuss that case, taking questions also from you, those who are attending. So please don't be shy, send in any questions that you want. Use the chat or the Q&A function, and we will do our best, myself and Dr. Iniu, to address all your questions. And we will do the discussion, as said, at the end of each session, of each case. So we have a BRCA-associated triple-negative breast cancer case, a HER2 positive with brain metastasis, and the last case will be on HER2 positive oligometastatic disease. So without losing any more time, let's go for the first case that will be presented by Dr. Al-Sendi from Ireland, and it's related to BRCA-associated triple-negative advanced breast cancer. Please go ahead.
Good afternoon, everybody. Many thanks for this opportunity to present the case. So my case today is a case of BRCA-associated triple-negative breast cancer. So our patient is a 68-year-old female. She initially had a diagnosis of left-sided breast cancer back in 2015. She had a TT2 node-negative triple-negative breast cancer. Her cancer was 34 millimeter invasive ductal carcinoma, grade 3. LBI was negative. 0 out of 2 sentinel lymph nodes were negative. ER negative, HER2 negative. She underwent left-wide local excision and a sentinel lymph node biopsy, followed by adjuvant chemotherapy with dose-dense ACT and adjuvant radiotherapy. In April 2019, she had recurrence on routine annual mammography. She had new focal asymmetry in the right upper quadrant of the breast. Her CT showed multifocal right breast cancer, but no definitive evidence of metastasis. The biopsy was invasive ductal carcinoma, grade 3, ER weakly positive 30 to 50%, PR negative, and HER2 new negative. So my first question to the faculty is, what strategy would you proceed with? Would you proceed with upfront first surgery versus neoadjuvant chemotherapy? And if so, what chemotherapy option would you proceed with, given that she already received anthracycline previously? So this patient proceeded to having neoadjuvant chemotherapy. She received gemcitabine and carboplatin for 4 cycles in November 2019, followed by a right mastectomy and axillary lymph node dissection. Her post-op histopathology revealed a residual invasive ductal carcinoma, grade 3. The largest foci was 2.5 millimeter. The cellularity of the tumor was less than 5%. No lymph nodes were involved, and she had prominent TILs with a residual cancer burden of 1. And at that stage, she was referred for BRCA testing and was found to have BRCA1 positive. So what would you recommend in terms of adjuvant therapy? Would you recommend capecitabine? And in 2021, would you recommend olaparib for this patient? And would you also recommend hormonal therapy, given that her tumor was VPR positive 30 to 50%? So I'll proceed. She did not receive any hormonal therapy. She attended regular visits for follow-up. She presented to the emergency department in February 2021 with fever, weight loss, and increasing shortness of breath. Her tumor marker was found to be elevated, and a CT scan showed multiple lung metastases, mediastinal hilar lymph nodes, and bone mets consistent with metastatic breast cancer. EBUS was advised to confirm histology. As you can see, she had multiple bone mets as well, and her EBUS showed triple negative breast cancer, ER and PR was negative, HER2 negative, suggestive of recurrence of the disease. She had a CT brain, which did not reveal any evidence of metastasis. At that stage, we also performed PD-L1 testing using the SP142 assay for atezolizumab, which came back as IC0 less than 0.5% inflammatory cells. So she received palliative radiotherapy to the hip and back, the areas of bone metastasis that were painful. She was started on talazoparib 1 milligram on March 2021. She had a good response from PARP inhibitors from March until June, with a reduction of her kind of symptomatic improvement and also a reduction in her CA15-3 tumor marker. She required dose reduction for grade 3 anemia and thrombocytopenia to 0.5 milligrams. We added Xgeva for her bone metastasis, and she developed a recurrent grade 3 anemia with an HB of 5.8 and low platelets, and that's when her treatment was stopped in May 2021. Her platelets have recovered, however, she remains requiring blood transfusion until recent. Her marker started rising again in June and early July. She developed hemoptysis. Her CTPA did not reveal any evidence of PE. However, it did show increase of her disease, of the size of the lingual mass and infrahilar lymph nodes. And that stage, she was referred for palliative radiotherapy for the hemoptysis. And her performance status was kind of declining slowly. And her hemoglobin, her last hemoglobin kind of remains around 8. Her platelets have recovered. So my third question to the expert panel is, what is the next optimal line of therapy for this patient whose bone marrow is still recovering or is compromised? Would you restart PARP inhibitor at a lower dose? Because she was off treatment from May until July, or kind of end June or July when she had the CTPA. Would you start second-line chemotherapy? Would you start sacituzumab govitecan? However, this is not available in Ireland. So this patient actually is still off treatment. Her performance status remains at 2. So we had a long discussion with her about what her optimal line of therapy, and at the moment she opted not to have any treatment because of her poor performance status.
Thank you so much, Maha. Very interesting case, and many things to discuss. Perhaps you want to go back to your first question to actually discuss that. That was in the context of her contralateral breast cancer diagnosis. So I think I think the question here that you asked us to address is, would we propose upfront surgery or neoadjuvant chemotherapy? And I guess this depends a little bit on what if breast conservation is possible. I would say that from seeing that this is basically T1 multifocal, non-triple negative according to the histology, there is not a clear indication for proposing a neoadjuvant approach. However, this can be discussed. I think that this can be discussed, and because of the underlying hypothesis that this is actually not a luminal cancer, but actually triple negative. I would say that in which concerns the type of chemotherapy, probably the proposed chemotherapy of gemcitabine and carboplatin is not the first choice. I would say that we have no evidence for using gemcitabine in the neoadjuvant setting. I mean, there's a trial that showed there is no benefit by adding gemcitabine. And I would say we still have some space to offer the classic anthracyclines. She received 4 cycles of anthracyclines and taxanes. If her cardiac function is good, we can still do that, or just use taxane and carboplatin. I don't know, Fatima, if you agree or would like to say something on that.
Sorry, I was on mute. So I think here we have to be very careful or not to classify something as triple negative if it is not triple negative. So 30 to 50% is not low, it's not ER low. So 30 to 50% is ER positive. It is not ER positive sufficiently high for us to be safe with endocrine therapy alone, that is correct, but it's sufficiently high for us to consider that is an ER positive HER2 negative and not a triple negative breast cancer. And if you have any doubts on that, then you should ask the pathologist to verify the accuracy of ER in another block of the biopsy or in another biopsy if needed. But you cannot classify something as triple negative when clearly it is not. And that had repercussions on your treatment and still has repercussions on your treatment. So that would be my first comment, is that for me, this is ER positive, HER2 negative, not triple negative, second primary cancer on someone who had an initial triple negative disease. Then I totally agree with Alex that carboplatin and gemcitabine is a regimen evaluated in the metastatic setting, not in the early setting. So it would not have been my preference. I agree that we could even repeat the same treatment that she had initially. I would probably not favor that in view of her age. She was 68, so already some the age factors, perhaps some comorbidities like hypertension could make me feel a little bit uncomfortable with repeating anthracyclines, but I would choose something like docetaxel platinum, which she has not received and would be, or even TC, which would be TC being the C being cyclophosphamide, would be acceptable regimen for this treatment and would be better tolerated. I have a tendency to go for neoadjuvant when chemotherapy is necessary because I can see the response to treatment. But it's, as Alex said, it's not indispensable in a case where you wouldn't be able to transform this into a breast conserving surgery. So that would be my comments for now. And I'll take the opportunity to ask the attendees to send some questions, since they haven't sent any yet.
Yes, and that is correct. Thank you very much, Fatima, for this comment. I think we're in line here. Then, if you would like to advance your slides to the next question, which related to actually what adjuvant treatment would you propose for this patient who, after receiving a non-orthodox neoadjuvant chemotherapy, only for 4 cycles, had some residual disease. Now, I totally agree with Fatima, and that was my comment. This is not a triple negative disease. So we have to take that into consideration. Therefore, when we think about the adjuvant, that is post-neoadjuvant treatment, there are 2 things. Capecitabine in the CREATE-X trial was, the trial was overall positive, but the main benefit came from the triple negative population. So this is, I would say, a discussion that, considering that she had receptor positive disease, I would actually much more favor the endocrine treatment for this patient in the adjuvant setting versus offering her capecitabine. In terms of olaparib, if that would be available, I mean, she's BRCA1 mutated, but there are 2 things. Capecitabine proved a benefit in the overall survival, while olaparib did not. The other comment is that olaparib proved to be effective for non-triple negative patients, in patients which were higher risk by the CPS plus EG score. Now, I don't know exactly how to calculate it right now, because you have to take into consideration the initial stage and the residual disease, but I doubt this patient would qualify actually to be enrolled in the Olympia trial. Therefore, to me, actually, the third option is here, the one, hormonal therapy.
So I would agree with you that there is a clear indication for adjuvant endocrine therapy for sure. So I would not have skipped. I would not offer capecitabine because, again, this is not a triple negative disease. If I would have access to olaparib, which is something we still don't have, but I would have access, I would verify if she qualifies on the classification of Olympia trial, but I would feel it's the second time she has a cancer, and it's the most targeted agent that we can get for BRCA-associated disease. So I would feel inclined to give olaparib if I could, but it is not mandatory, as you said, and correctly, we still don't have survival data, but we have a substantial invasive disease survival data, which is quite interesting. So at the present time, I would give her endocrine therapy. At in the future time, perhaps I'll give endocrine with olaparib.
Thanks so much, Fatima. And on to the last question, a little bit quickly, because we are a little bit late on time. So she got recurrence. She had a good response to talazoparib, which had to be stopped because of toxicity, and then she progressed. What is the optimal next line of therapy? I mean, this is anyone's guess. I think we don't have so much data on PARP resistance. In view of the tolerance, of the bad hematologic tolerance that she had after talazoparib, and what we know with PARP inhibitor, that it tends to remain there present, I would probably favor a low toxicity chemotherapy regimen, monochemotherapy regimen, and perhaps, I don't know, capecitabine or even metronomic treatment with capecitabine can be an option for this patient.
Well, I would remind the endocrine therapy, right?
Yeah.
So you have here a patient with 2 tumors. Let's say she had initially a triple negative, now she had a ER positive, and now she has a relapse, right? I don't remember the biopsy. What was the biopsy?
Triple negative breast cancer.
Oh, then it was the triple negative. Okay.
Yeah.
So if it was the triple negative, then I agree with you. First, let's see if she recovers from the bone marrow. I'm always hesitant in saying that it's totally toxicity without knowing if there is infiltration of the bone marrow. She had several bones with the disease, so it may be infiltration of the bone marrow. It's something you have to exclude. She had platelets and also anemia, so more than one cell line going down, verify if it is invasive of the bone marrow, because then you treat in a different way. And if not, something lower dose of either oral vinorelbine, metronomic CM would all be very acceptable options, of course. And finally, we have 2 questions from the audience.
Yeah.
So, can we associate endocrine therapy with olaparib? Yes, you can. Endocrine therapy only with olaparib. This was, as you know, ER-positive disease was accepted in Olympia trial and was given concomitantly with endocrine therapy. So, and the benefit was seen irrespective of being triple negative or ER positive for as long as they had the risk, the high risk calculated by that formula.
Yes.
So maybe we move on for the second case.
Thank you.
Yes,
Thank you.
thank you so much, Maha, for the interesting case. We move over now to the presentation from Marina Puchinskaya from the Minsk Clinical Cancer Center in Belarus. Marina, the floor is yours.
Okay, many thanks, Professor Anu, for the introduction, and many thanks, ESO, for this wonderful chance to present here a case of HER2-positive breast cancer with brain metastasis. So that is a story of a 49-year-old woman with no serious comorbidities and no family history of cancer, never smoker, and with 1 childbirth in past, who presented to our center in May 2018 with complaints of right breast discomfort and swelling. Her right breast on physical examination was really edematous and hyperemic, with skin hyperemia and nipple infiltration, and without no definitive underlying nodules on palpation. On mammography, there was skin thickening and microcalcifications seen that appeared to be benign with atypical ductal hyperplasia on corneal biopsy. However, on breast ultrasound, there was a nodule found with irregular boundaries, about 1 centimeter, that proved to be cancerous on corneal biopsy. And besides that, multiple axillary, subclavicular, and supraclavicular lymph nodes were seen on ultrasound that proved to be metastatic on finding aspiration cytology. No evidence of distant metastasis was seen on examination, and this case was classified as invasive carcinoma grade 2, ER positive, progesterone receptor positive, Ki67 high, and HER2 3+, that is positive, on corneal biopsy with CT4B and 3M0. The treatment began with neoadjuvant chemotherapy with 4 cycles of doxorubicin cyclophosphamide, followed by 4 cycles of docetaxel and trastuzumab. She began trastuzumab from September 2018. That was followed by mastectomy, Madan, in December 2018. On pathology examination, it was PCR that was like a good prognostic factor for her, though we know it may not also be associated with a good outcome. And the treatment was followed by radiotherapy on chest wall with axillary and supraclavicular regions with 50 grays, adjuvant trastuzumab up to 1 year, and adjuvant tamoxifen, as her tumor was estrogen receptor positive. Again, no evidence of disease progression was seen on regular checkups until 2020, but the story was completely different in February 2020, when the patient had some discomfort, pain in the neck, and stiffness, and she decided by herself to undergo spine MRI. And on that neck MRI, on the upper levels, as an incidental finding, a brain lesion was seen. Interestingly, the patient had no neurological signs or complaints regarding her brain at that time, except slight decrease in visual acuity that she didn't thought was connected to her disease. So it was totally an incidental finding of a brain lesion in the right occipital lobe in cortical and paracortical regions, about 2 centimeters in diameter, that was seen, and that was seen to be possibly metastatic. Then she underwent PET-CT staging, and no other lesions were seen on her PET-CT, except for that metastatic one. And so she was consulted by a neurosurgeon that said that technically removal was feasible, but the lesion was very small. All the possible treatment options were discussed with the patient, but she refused neurosurgery or whole brain radiotherapy at the time, and so she went on with stereotactic radiosurgery with 20 grays in March 2020, and continued tamoxifen. And here we come to the first question on would you change systemic therapy at this time point? Though I think after ASCO guidelines in brain metastasis, it's not really a question anymore. But anyway, we're coming back to our patient. On brain MRI follow-up in August 2020, that is 5 months after stereotactic radiosurgery, slight enlargement of the lesion with contrast enhancement and vasculated areas were seen, but at that time it was considered to be possibly a pseudoprogression. So no further treatment was recommended, and control MRI 2 months later showed that it was really pseudoprogression and stable disease at that time. So that's how it looked like. And here we come to a second diagnostic question on how can we differentiate pseudoprogression from real progression. So do we have any other criteria except for time course? Because, for example, if it was a real progressive disease, so I think waiting for 2 months could have been not a very good option for the patient. So again, she got regular MRI checkups, but in January 2021, the growth of the previously existing lesion was seen with no new lesions, and it was clearly progressive disease at that time, that is with the lesion. So on February, she underwent surgical removal of that senile brain metastasis with local application of his cisplatin. So it's a procedure widely approved in our country. But as after the operation, there were residual areas of contrast enhancement in the postoperative cavity, about meters. So she also underwent postoperative radiotherapy with 30 gray applied to the postoperative cavity, and again tamoxifen was continued at that time. In May, again, there was progressive disease on MRI with a localized meningeal carcinomatosis in temporal occipital area and cerebellum, and enhancement of postoperative cavity walls. And I should notice that all that time checkups showed no signs of distant metastasis elsewhere. So this lesion was the only one that was progressing. So here you see those enhancement in meningia and enhancement in the postoperative cavity. As local treatments were no more possible at that time, it was decided to go for the change of systemic therapies, and capecitabine and patinib were initiated, and she tolerated the treatment really well, with only grade 1 leukopenia and anemia seen during this treatment, and this treatment is now ongoing, and her brain MRI in August showed stable disease, and again, no signs of other metastasis. And so we come to the third question on what would be your next treatment option in case of progression, and will it differ if progression is only in brain or if it is systemic elsewhere? Again, would you choose for TDL1 or maybe TDXD now after ESMO this year, regarding good results of trastuzumab deruxtecan, or maybe chemotherapy or tucatinib, unfortunately not available in our country. So with my case, I wanted to stress that though we have many different trials, and we're talking about evidence-based medicine many times, however, in some clinical scenarios, we do not have enough evidence. For example, HER2-positive breast cancer is the most frequent subtype of breast cancer to metastasize to brain, and breast cancer is the second leading cause of brain metastasis. However, as it was shown by a very nice paper by Corbett et al. In German Oncology this year, breast cancer patients were the most frequent to be with brain metastasis to be excluded from any clinical trials. And again, it seems like we have two different ways of treatment in breast cancer. So some scientists develop different ways of local treatments like neurosurgery, radiotherapy with different regimens, series, and everything like that. And other groups are developing systemic treatments with hard-to-targeted agents or chemotherapy and everything like that. But we have still very little data on how to combine or sequence those strategies, and we do not still have enough evidence on brain metastasis. And I would like to draw the attention of the audience to this wonderful review that was published also this year with a review of different clinical trials. Here, there are also only phase 3 trials on HER2-positive brain metastasis with different brain-related outcomes. And for example, Cleopatra, Meadow, Cerebral, they specifically addressed the frequency of brain metastasis, and we have only very early preclinical and retrospective or phase 1 and 2 data on the combining of different options. So thank you very much for your attention.
Oh, thank you. Let's go back to your first questions. So regarding, I'm just going to make one comment about the treatment in the early setting. And of course, everything is mandated by availability, and possibly there's no availability of, can you go back? Oops.
Sorry?
I don't know what happened to the presentation. We lost. So anyway, I'm going to say what I was going to say is in the adjuvant setting, for such a very locally advanced breast cancer in the adjuvant or neoadjuvant setting, in the early setting, we should try pertuzumab. These are the indications for pertuzumab. Is this very locally advanced disease, M3, so clearly positive nodes. So of course, if you don't have access, you cannot do it. But if you have access, this would be a good indication. The other thing that I would do, so the lady was 49, possibly would have become menopausal after the chemotherapy. But if not, we should induce the menopause and give her an aromatase inhibitor. But possibly she became menopausal with the chemotherapy. That was one comment for the early disease. Now for the brain metastasis. So, and this is the correct, what you did is the correct. You assessed that it's a single lesion, asymptomatic, amenable for surgery. And if it is possible to have surgery, this should be done. And if it can be replaced by stereotactic radiation, that's the first option. Whole brain radiation should be reserved to the last time that we need to give it. So the lady was right to refuse whole brain radiation because she didn't need it. Okay, so she should have received either neurosurgery or stereotactic radiation. Now here is the first time where I strongly disagree with what was done. So it was continued tamoxifen alone, and here trastuzumab should have been restarted. So ESMO and ABC guidelines and ASCO guidelines are very clear to say that anti-HER2 therapy should be restarted if it had been stopped, which is the case here. And the drug for which we have more data on restarting for an isolated brain met is trastuzumab. So here what you should have done was, you could have continued tamoxifen. I would have switched already for an AI, but it's fine. Tamoxifen is not wrong, but trastuzumab should have been added. Unless in your country you cannot use trastuzumab beyond progression, which is clearly a big problem in Eastern Europe, and a very wrong decision of your health system, right? It's probably that case, right, Marina?
Yes, I can comment that pertuzumab was not available at that time, so of course, definitely there was a clear indication for that, and yes, unfortunately, we can't proceed with trastuzumab beyond progression.
Okay. Because that is the clear indication here and would have saved this lady, could perhaps gain many years of a stable disease if we could have done that. But unfortunately, these are the problem. Then you can move forward. About what you call pseudoprogression is what we sometimes call radionecrosis, a consequence of stereotactic radiation. Diagnosis is very difficult, and usually you need experienced radiologists to help us, right? And also time, you can wait a little bit. But when radionecrosis is symptomatic, you should treat with steroids. This is the first treatment, is steroids, okay? And possibly it will resolve. If it is not symptomatic, we can wait and see. So, but it's a difficult differential diagnosis between one and the other. Please go ahead to your next questions. No, I think you had one previous that I wanted to. So before that, something you did?
No, only on pseudonecrosis.
No, and then next. So when did you give her this thing that I have never heard of getting platinum inside the brain? So you cannot.
Yes.
It's amazing what people do without evidence.
There was a national trial of cisplatinum application in brain metastasis removed of different tumors. So it's a procedure that is used in our country rather widely. So though I know it's not approved in other countries.
So it's not. It's very bad because it's eminence-based medicine, completely nonsense. You can say that to all the oncologists in your country that I said it, so it's not your fault, it's my fault. But it's complete nonsense to be giving cisplatin inside the brain with all the other techniques and treatments that we have today. So you should unite yourself in your country to have access to proper anti-HER2 therapy and not do this kind of application. So here what was indicated was surgery, like it was done, and nothing else, because she had already received stereotactic radiation there, and there wouldn't be an indication for whole brain radiation at this time, although that is something that you could discuss. I think giving radiation again to the same place would be very debatable for the majority of radiation oncologists, but I will leave it there. The same comment on systemic therapy. So anti-HER2 therapy should have been started. And here, at this time, I would say that if you could not restart the trastuzumab, then here would have been the time to change to lapatinib. Okay, and it is not the optimal treatment, but it is what you have. But it's the second progression, so I would certainly have given her the anti-HER2 that you have before the progression that happened afterwards, which is a very bad prognosis progression with meningitis, so carcinomatosis meningitis. And if you go ahead in your questions, in your next slide. So here, I think this is the option that you have. Obviously, you do what you have. If it would be in the ideal world, this would not be the ideal option, because the Cerebell trial that you have shown has clearly shown that even trastuzumab plus capecitabine is better in terms of survival than lapatinib capecitabine, right? So the option here would be, for example, TDM1 is a very good option, also has some effect in the brain. And in the ideal world, tucatinib would also be one of the best options to give. And in case of a next progression, it doesn't really matter if it's in the brain only or systemic, because you are already going far ahead with the progression of the disease and you have a very bad prognosis situation of meningitis carcinomatosis. So it would be these options that we are discussing, TDM1, tucatinib, whatever you have available, okay? I don't know, Alex, would you add something else besides, please tell me that nobody else is doing intrabrain cisplatin?
No, I know. I don't have anything else to add except that we have a question, but we also have limited time. So I guess I will actually thank you for that and move to the next case because we are a bit late. So
yes, because the question was on early setting. So
yeah.
Without disrespect, we're going to ignore it. So we
We'll
will
answer it in writing.
I'll reply in writing. Yes, I'll reply in writing. So let's move to the third and last case. And Dr. Lucia, I'm not going to try to say your surname because I don't want to make a mistake.
No problem.
From Buenos Aires, Argentina, please discuss with us HER2 positive oligometastatic disease.
Hi everyone, I'm Lucia Kaminsik from Buenos Aires, and my case is about HER2 oligometastatic advanced breast cancer. I don't know why I can't. No.
You have to double click on the image and then it will work. Yeah.
Yes. Okay, that's right. She's a 59 years old woman with clinical history of former smoker and hepatitis A virus, and she was diagnosed with right breast cancer stage 2A at January 2017 with negative hormonal receptors and HER2 positive. She started treatment in a different institution with the lupectomy and sentinel node biopsy that informed a 2.5 centimeters breast carcinoma node located on the lower right quadrant with positive vascular lymphatic invasion and a grade 3 with 35% of Ki65 and positive margins, still negative hormonal receptors with HER2 positive and negative sentinel node. Because of the positive margins, 5 months later, it was performed the right mastectomy with expander placement, and it was a ductal carcinoma in contact with Chinese ink infiltrating margins with 7 centimeters and micropapillary pattern with lymphangitis carcinomatosa. Then she started the adjuvant therapy with adriamycin and cyclophosphamide for 4 cycles on August 2017, and intra-adjuvant CV therapy, the patient found a palpable lymph node on the right axilla, and it was a macrometastasis of ductal carcinoma nodes without capsular invasion. The total body tomography showed no evidence of distant metastasis, and because of a unique nodal local relapse, it was decided to complete the 4 cycles of adriamycin and cyclophosphamide by adding 4 cycles of trastuzumab and docetaxel and the subsequent axillary lymphadenectomy. It's still in a different institution, I have to say. So in April 2018, the right axillary lymphadenectomy was performed. I think it was a bad surgery because no ganglion structures or vascular embolies were found and no neoplastic colonization was found in the sample. And during the surgery, it was observed isolated cutaneous lesions in the surgical bed of the right breast. So there were samples for further testing, and it were cutaneous metastases of breast carcinoma. So in May 2018, the patient started the first-line therapy with trastuzumab emtansine because of the local skin involvement. Then the total body tomography showed persistence of axillary nodes of 15 millimeters, and she started trastuzumab emtansine with 1 year later, complete response of skin metastasis and stable nodal disease. From 2018 to 2021, the stable nodal disease has been observed with TDM1. And in May 2021, the patient starts follow-up in our institution with a TC that informs a 41 millimeters right axillary nodes that were disease progression by RECIST with a tumor marker stable. So we asked to do a PET-TC that showed 3 retropectoral and right axillary images with a normal increase of FDG. The biggest one was 45 millimeters, and the biopsy informed metastasis of breast and ST carcinoma with hormonal receptors negative and HER2 positive with negative vascular lymphatic invasion and perineural invasion. So the questions to the experts are that, taking into account that breast cancer is initially assumed to be a systemic disease in our patient with stage 4 disease due to cutaneous involvement since 2018, do you think does exist any benefit of prescribing a pseudo-neoadjuvant therapy with following resection of the persistent disease versus a conservative behavior with a second line and local radiotherapy? I don't know if you want me to ask the second question.
I actually think that this is, thank you for the presentation. I think I would like to go back to the initial presentation and clarify what happened between between the lumpectomy and the mastectomy, because I guess this is where the battle was lost. So she had the lumpectomy and sentinel node biopsy in January, and then in July, that 6 months afterwards, she had the right mastectomy with for something that was already very suspicious, a ductal carcinoma in situ of 7 centimeters.
Yeah.
So what was the reason for the delay?
I think the patient was treated in another institution, but I think the delay was like surgical availability. Maybe.
I mean, to me, it seems that this patient was never disease-free from the initial time of treatment. And therefore, what happened next is just, trying to catch the disease that already has gone. And
maybe, Alex, by saying that, I think we should ask everyone. So if you have delays in surgery, it is okay to finish surgery after adjuvant treatment. So you could have given her the adjuvant treatment after the first surgery, and then you would complete the surgery afterwards. And then you could save her. You see what I mean? So instead of being 5 months without anything, you would do the chemotherapy and the trastuzumab and plan for the surgery to be done afterwards.
Absolutely. I think this is because, and then to come to your other question. So you were asking the pseudo neoadjuvant. Already we have just a little bit of data that pseudo adjuvant, that is systemic therapy after resection of a local recurrence, is of benefit, especially in receptor negative patients. You should offer chemotherapy. This is what we know. For the receptor positive, you should offer hormone therapy. So my comment here was that if the patient had an initial isolated cutaneous metastasis, that was perhaps also another possibility to cure her, that is to excise that metastasis, to try to become disease-free, and then to offer a pseudo-adjuvant therapy for the patient to decrease the risk.
I would agree that here we are trying to recover for bad management. And we're not saying it was your fault, not at all. She was treated in different institutions, but here in HER2 positive disease, as in all diseases, but HER2 positive, time is crucial because it is a disease that you can have very good outcomes if you don't waste time to give the most important treatment, which is anti-HER2 treatment. So, and then for very limited systemic disease like small cutaneous metastasis, if there is a possibility of removing that and then give the systemic therapy, that is again one possibility of rescuing the patient, because very quickly it will be out of control. So here, have you started anything?
We are planning to start 6 cycles of carboplatin, docetaxel, trastuzumab, and pertuzumab, and see if we can perform the axillary surgery and the two lesions of retropectoral.
Do you have access to TDM1?
Yes.
You had TDM1, Fatima.
Yes.
She had TDM1, okay.
From 2018.
I would not go with such a toxic regimen. So, okay, if you can have access to trastuzumab, pertuzumab, but then do the Cleopatra regimen, not with combination chemotherapy. You're not going to improve anything with combination chemotherapy. You can do with either docetaxel or with vinorelbine or even with capecitabine, trastuzumab, pertuzumab, but not with combination chemotherapy.
Yeah.
Okay.
Totally agree, and then try perhaps, although again, surgery here seems a little bit difficult. And of course, if on the theoretical side, we don't have that much data with trastuzumab, pertuzumab after 2 years of TDM1, so that leaves a question there. But because of the evolution of the disease, we are a little bit outside of the guidelines here, so we have to use best.
Well, unfortunately, she was not treated according to guidelines from the beginning, right?
Yes.
Yes.
So I think the best option here would be trastuzumab, pertuzumab, and one chemotherapy, not more than one.
Okay.
And the only reason to go for surgery is if you have an excellent response and you have just a small persistent disease in the axilla. Otherwise, this is now a systemic disease.
Okay, maybe local radiotherapy could be an option, do you think?
Maybe if she has not received yet.
Yes. Okay, perfect.
And there is one question in the chat asking if we stop the trastuzumab treatment in the adjuvant of metastatic setting if it is stable disease with progression only in the brain. And I guess this address.
No, you don't. So as I said, one of the things that is mandatory, even if you have an isolated brain mets, is to continue anti-HER2, particularly trastuzumab, unless you're going to give something else, like if you're going to give TDM1 or something, but you keep the trastuzumab. So I guess we have to stop, Alex.
But I'm very satisfied to see that we still have the participants with us. So that means that was interesting. So I thank you. I thank you all for the present, for the time taken to prepare these cases and to discuss them, and the courage to discuss them with us. And I really commend you for the nice presentations. And if someone can advance the slide, that I can close by saying that we very much appreciate and that we think these clinical cases are, as we have seen from the participants, are interesting and provide good feedback and good information to the patients, to the participants. Therefore, please join us for the next ones. The next ESO session is how to assess plan quality in radiotherapy treatment, and then The expert will be Professor Pier Francesco Franco from Novara, Italy, and the discussant will be the Dr. De Bari from La Chaux-de-Fonds in Switzerland. So thank you very much for everything. Thank you, Fatima, for taking the time, and have a good evening, morning, or night. See you next time.